The unmet needs for systemic therapy in kidney cancer in the TKI era are that few patients achieve complete response or complete disappearance of their cancer. The toxicities, all of these drugs have toxicities, although they're managed, but they are chronic toxicities that can bother patients for essentially all the time that they're on the treatment. One of the most troublesome side effects for all these therapies is diarrhea. And so patients with chronic diarrhea really can impact on their quality of daily living in a major sense. The same with skin toxicities. So the toxicities that we see with these drugs, the lack of complete response. We've also made tremendous progress in managing kidney cancer over the lifetime of the patient by, in certain respects, changing it to a chronic disease that's managed by these different medications. But still, most patients with metastatic renal cancer will ultimately die from this cancer, so the cure of patients remains an unmet need. Advanced renal cell cancer was historically considered to be one of the most difficult cancers to treat and associated with a poor prognosis. In the days or the era before the targeted therapies with TKIs, the median survival for patients with advanced renal cell cancer following diagnosis was between 8 and 12 months. There was dramatic progress that was made based on the understanding of the importance of the von Hippel-Lindau gene in regulating angiogenesis for renal cancer, and the fact that most clear cell carcinomas of the kidney have mutated VHL genes. That really served as the basis for the study for sunitinib and the other VEGF TKIs in this disease that have changed the paradigm for how we treat kidney cancer as well as the prognosis. There were a number of these VEGF TKIs that could kind of be considered as first generation. They were studied in the 2000 to 2010 era, and they include sunitinib, pazopanib, and axitinib, and as well as sorafenib. And they were all approved for different indications and were widely used for the treatment of kidney cancer. More recently, there's been newer agents that differ from these drugs with respect to targeting profile or mechanism of action. And so I would say within the last 5 years, these have been studied and brought in almost as a new generation for treatment for kidney cancers, as emerging treatments. And these include nivolumab, which is a checkpoint inhibitor, cabozantinib, which is a VEGF TKI that targets not only VEGF receptor but MET, and also the lenvatinib, which is a new, very potent tyrosine kinase inhibitor that targets VEGF receptor, platelet-derived growth factor receptor, as well as the FGF family. So these drugs have been studied and brought into use in our clinic within the last 3 to 4 years. More recent, even beyond that, these drugs are being combined with checkpoint inhibitors now, lenvatinib and axitinib, combined with checkpoint inhibitors with very promising results in single-arm phase 2 studies, now all in phase 3 trials. Checkpoint inhibitor combinations just recently been reported and will likely change our first-line treatment plan away from sunitinib to ipi-nivo. What I see moving forward that is particularly promising are the combinations of the VEGF-targeted therapies and the checkpoint inhibitor therapies. And most of the single-arm studies with axitinib and pembrolizumab or with lenvatinib and pembrolizumab, the single-arm studies have shown response rates of almost 70%, which is more than double that which we've seen with sunitinib. So there are a number of large randomized phase 3 trials that are evaluating these various combinations compared to sunitinib, and I'm very hopeful that they will show a positive effect and result in another great gain in the benefit of kidney cancer patients to our systemic therapies.